I'm good.
Ron,
We will call the Human Services Committee meeting to order. You receive copies of the minutes. Any corrections or emendations?
Move the minutes.
Is there a second?
Second.
I'll second.
Mr. Berg, discussion. Hearing none, all in favor, please say aye.
Aye.
Opposed, same sign. Motion is hereby carried. And to begin this morning with Denise. Good morning and welcome.
good morning, Denise.
Morning. That was quick. So I'm coming before you today from Public Health to talk or make a recommendation for a change in how we come about our vaccination fees. So I want to start out first to make it clear that you understand the vaccinations that I'm talking about. So we get Minnesota Vaccine for Children, vaccine for children 18 and under. We also get vaccine from the state under a program called the Un- and Underinsured Adult Vaccine. So what I'm talking about doesn't affect either of those groups. So the people that come to our office for vaccines that either are un- or underinsured are still able to get vaccine at a reduced rate, and or if they're unable to pay, we don't turn them away. So what I'm proposing a change to is the vaccine that we purchase privately and administer. So historically, probably in the last 15 years, if you will remember, each fall we come before you with public health fees. Our vaccine fees are part of that. What we've done for the past 15 years is take the actual cost of the vaccine, round that up to the nearest dollar, and then add our administration fee. What I'm proposing is a slight change to that, and I'm proposing that we take the vaccine fee, add 10% of the cost, not the fee, 10% of the cost of the vaccine, and then add the admin fee. It's a slight change, but it should help to cover our costs in administering these vaccinations. So just to make that look a little real for you, the types of vaccines that we offer privately, either private pay or through insurance, tetanus, Tdap, hepatitis A, hepatitis B, and flu. We do a lot of worksite flu clinics in the fall. So let's just take flu, for example. Usually it's in July when we look at vaccine costs. We look at how much does it cost when we order these, and then we set our fees accordingly. So we just looked at that in July. So flu for this fall, a flu shot would cost $37. With what I'm proposing, the change, it would cost $39. So it's minimal, but it's a little bit of a change and just an effort to cover our costs. Do you have questions?
Questions for Denise?
Chairman, how many flu shots, for example, do you give out in a year?
It's somewhere between 1,200 and 1,300.
Is that the highest usage?
It is, for the private vaccines, yeah. Yeah, we do a number of hepatitis B shots. Some people will walk in, but most of our hepatitis B is for either employees, county employees, or other employers will send employees to us to get their hepatitis B vaccination. And in those cases, we're either billing their insurance, most of the time billing their insurance, or we may be billing the employer themselves, because they are obligated to cover that.
Mr. Kleindl.
Mr. Chair, as I'd remind the board, it's always best to gradually do increases instead of not passing up on doing an increase and all of a sudden you got a big leap. It's better to do it over time instead of waiting years and years and all of a sudden you have a big increase. A $2 a vaccination, most people couldn't even get a cup of coffee for that.
Mr. Chairman, and when was the last time it was increased?
I'm thinking about either 14 or 15 years ago is the last time that we made a change to how we figure our fees.
All right.
So it's been a significant amount of time.
Thank you.
Further questions? Is there a motion to accept the proposal?
I so move.
Commissioner
second.
Berg moves second. Discussion? Hearing none. All in favor, please say aye.
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 Opposed, same sign. Motion hereby carried.
Thank you very
Denise.
much.
Thank you. And Mary Jo or Lynn? Whichever one who's going to start, you start, please.
Okay. We have to get our PowerPoint going here quick.
I don't presume that the name at the top is going to start all the time, and so I called you both at that point. 'Cause I-
Okay.
See any picture?
Try hitting it again. Might have to hit it twice. Is it thinking? There we go. I hope so.
You should have all voice
Got
acting.
everything but the kitchen sink in here, but
Well,
Never have to plug anything in.
now I need the kitchen
I
sink.
think what we need to do is get a computer that's not from the 70s.
These are the note, this is the
yeah.
note paper I'll use.
Upgrade them
I shouldn't be able
from
to
the
fill
processors, yes.
anything anyway. Oh,
It always works beforehand.
yes.
Always works. Yeah. Test it out, it works.
Hey Logan, if you're listening, we could use some help.
Over here, there.
Huh?
We could run it over here.
You can
run it over there? Yeah, switch back to this monitor,
Okay.
so. You want them to jump right over there? Yes, that would be great.
If anybody.
Oh,
can figure it out,
here it
Mary
comes.
can.
Here comes the technical advisor.
Our tech person just showed.
He was listening.
Camera guy.
So it's supposed to go on those screens right there?
Yep.
Yeah.
Okay.
So I just went back to the other one, but
That didn't work for you either.
see, at least I tried.
Otherwise, just give it to Mary if she can
Yeah.
do it too. That's,
Okay.
because I don't want to cut you short on time.
We do have one slight change. Don Platson got called for jury duty this morning, so
Oh,
she makes it back. We're one short of
that,
our
that,
presentation. She may make it back, but
Yeah.
pull it,
Yeah, you can just go over there.
pull it.
Yep. Good.
So we're gonna, well, we'll be using that at the next board meeting too, so I don't know what's going on here.
Okay.
So maybe between meetings, we can,
Yeah, I'll come back.
thank you, I
thank
appreciate your
you,
help.
thank you.
I knew he was in recording, so.
Yeah, I was wondering,
The DAC is having problems with their PowerPoint. And I said, well, come on early to help you.
Well, there's something.
and that isn't lining up either then.
There we go.
Okay.
Well, it's gotta be the laptop.
There you go.
Okay.
There we go.
Yes,
Good morning.
Good morning.
Good morning.
I am Lynn Gatewood and Mary Jo Kathleen. I have worked with probation for 22 years here in Candy-White County, and my career has been mostly in intake and pretrial. In the last year, I moved over to a mental health unit and have learned a lot and enjoyed a lot about learning about this case code, and would like to share that with you today, what we are doing with mental health and corrections. First of all, I would like to give you some examples of the persistent and serious mental health disorders that we often work with in corrections. They include, and are not limited to, depression, anxiety, bipolar disorder, borderline personality disorder, schizophrenia, multi-personality disorder, post-traumatic stress disorder or PTSD, fetal alcohol syndrome, obsessive compulsive disorder, autism spectrum, traumatic brain injury, antisocial personality, attachment disorders, and ADHD and ADD. The history of mental health in Minnesota is long. Prior to 1978, Minnesota had 11 large state-run mental health hospitals, Wilmer being one of them. After 1978, Minnesota began closing all state hospitals except one, deinstitutionalizing the mental health population. Anoka State Hospital remained open with 110 beds. Minnesota set up 7 smaller facilities, with each having 16 beds. And St. Peter facility was developed for people whose mental illness led to crime. Mental illness today. Most mentally ill individuals are in the community and don't come into contact with law enforcement and probation. And it's important to remember that. There's a lot of people who live with mental health that are not involved in the criminal justice system. However, corrections has seen a population increase in clients with mental health issues in the court system. Some individuals may be a risk to themselves or public safety and do have contact with law enforcement and probation departments. They often have chemical use issues. They may not be taking their mental health medications as directed and thus using chemicals instead to self-medicate, and they may not have support systems and may be living homeless. Mental health facts in America I'd like to share with you. 43.8 million adults experience mental illness in any given year. 1 in 5 adults in America experience a mental illness. Nearly 1 in 25 adults in America live with a serious mental illness. The consequences of mental illness. 10.2 million adults have co-occurring mental health and addiction disorders. 26% of homeless adults staying in shelters live with serious mental illness. 24% of state prisoners have a recent history of mental health conditions. 60% of adults with a mental health illness did not receive mental health services in the previous year, and 50% of youth aged 8 to 15 did not receive mental health services in the previous year.
So my name is Mary Jo Kathleen, and I've been in the criminal justice system for 33 years, and have done this caseload now for 4 or 5 years. So those are pretty startling and sober facts that Lynn read to you in regard to mental illness. And so what happens to people when they come into the criminal justice system and when they have these issues? So those are some of the things that I'm going to touch on today. In a mental health crisis, people are more likely to encounter police than get medical help. And as a result, 2 million people with mental illness are booked into jails each year. Nearly 15% of them are men, and 30% of women are booked into jails, and they have a serious mental health condition. The vast majority of them are not violent, and sometimes once in jail, many individuals don't receive the treatment they need. Some medications that they might be on are not allowed in the jail, and they don't get out to receive their counseling. So once in jail, they might not receive the treatment they need. They are at a risk for victimization in jail, and often their mental health conditions continue to deteriorate if they don't get the help that they need. After leaving jail, many no longer have access to needed health care and benefits. So I've had a couple clients that once they have been incarcerated, when they get out, they have to start the whole process over as far as getting their health insurance and their disability reinstated. In addition to their mental health illness, when they come out of jail, sometimes they have a criminal record, which often makes it hard for them to get a job or maintain housing. So the population that Lynn and I supervise, what can we do about it? Well, several years ago, we realized that this was becoming a problem, and that we had a lot of agents that were dealing with the mental health crisis and on our caseloads and just not knowing where we should go. So a few years ago, we decided in our agency to take 2 agents in our office to be more specialized in the mental health area and supervise offenders with more serious and persistent mental health. I have been one of those agents, and Lynn joined me a few months ago.
Yeah.
So It is very helpful to have the specialty with the mental health case because we can help navigate the system with our offender. And our caseloads average about 65 clients per agent. Our caseload consists of individuals who have persistent and serious mental health disorders. In order to supervise these individuals, we need to assess their risks and their needs. And we do that by using our evidence-based practices and our professional alliance skills so that we're able to help our offenders be successful. The first thing we do is we assess their risk and assessing their risk and their needs of the offenders and what are they going to be needing to have to be successful. One thing that we look at is their responsivity to probation. What is going to inhibit them from not making the right choices or not following us along to help them improve their life situation? So many considerations we look at is their motivation. What is their motivation to change? Are they in any denial or minimization of their offense? Are they anxious? Do they maybe have an education or low intelligence? Do they have some communication factors such as a language barrier? And then this is where ours come in, is to mental health, and some might have antisocial personality or psychopathy. So in order to meet these people or these individuals where they belong and where we can help them out is we have to use some of our professional alliance skills. So Lynn and I have learned to be very understanding, first of all, respectful, very respectful to our clients. We've learned to be attentive to their needs and listen to their story to build that trust so that we're able to help them along and improve their life. I have found, at least in my caseload, that if they really trust me to help them, they know that they're going to be having a better life afterwards. And I think Lynn has learned the same.
Exactly, yeah.
So we have a couple of examples where our days don't always, as in the work world, don't always go the way we had planned. We come to work and we have certain duties, certain things we're going to get done, and then we have someone that comes in that has a definite mental health issue. One day I had a person that came in and it was just a regular appointment, and while we were talking about things, she became disassociative, which means she wouldn't react to me. She just sat in her chair and wouldn't do anything to get out of it. In that moment, I was able to call one of our partners, Mobile Crisis from Woodlands, to see if we could get her to a point where I could have her safe again. In talking about it, it sounds like it would be only seconds that it would take, but it was a half-a-day process in getting Woodlands on the phone to getting Mobile Crisis couldn't come because she was already a patient somewhere else. So getting all that factor in, but eventually we ended up calling the ambulance and they took her. But that's just one instance where, you know, your day doesn't go as planned and you have emergencies that happen.
Mm-hmm.
And I think, Lynn, you've had the same
Yeah.
thing happen to you.
Every day is different. There's lots of challenges and corrections with any caseload. And with a mental health caseload, you just never know who's going to be in front of you. One of the things that came to mind is I had an individual come into my office, and things aren't always as they appear. I was meeting with this individual and explaining to him that some of the things that he needed to do, and he didn't like what he was hearing, and he proceeded to throw himself on the floor in my office and gave a little bit of a tantrum. That's unusual behavior. My coworkers walking by the office thought that there was a medical emergency, thought that I was in danger. So they were heightened in their response to this. But it just turned out he just needed to be calmed down. We needed to talk it through, and we got him back up in the chair and were able to finish our meeting. But definitely wasn't expecting something like that.
So some of the things can be very volatile, as Lynn said. But the majority of our cases, I think, and I feel, go through our system and are better off. Again, like I said, we also do a lot of collaborations on this caseload. We work with Woodland Centers, we work with Rice, we work with HRA in finding people, trying to help them find housing. We work with the jail and MEND. The nursing staff at the jail has been very awesome to work with. And then whenever we need to help someone with mental health, we always try to meet with family services, and that has been really imperative to our work and to get someone stable, and get them stable before the fact. So if we have someone coming out of jail that needs housing or needs something, we're able to social workers, Woodland Centers, and then other mental health facilities. And that is just what's up with mental health, basically, and how can we make it better and streamline the process for everybody. Also, Salvation Army counselors, anybody that we can help with our individuals that we work with. And then, of course, we want targeted results. What are our results when we're working with these individuals? We obviously are results orientated. And some of our targeted results are, number one, we don't want them back in our system, right? We want them to be stable. So we're looking out for our public safety. We feel that our public safety is increased by working with these individuals more closely in a specialized setting. We also have their individual safety in mind, that they come out having a place to live, maybe working, having their mental health stabilized. And then trying to address the needs of the individual, which include maybe chemical dependency, because most of the individuals might have a chemical dependency problem along with the mental health. Their problem-solving skills, coping skills, how do they cope? And then, like I said before, education, housing, employment. I think one of our main goals is to enable the individuals to be able to stay in the community and with their supports and reduce our hospitalizations and any jail time that they may receive. But one of our ultimate goal, I think most of us that are working with this caseload, is to let them see that we are a partner with them to make their life better, and that we're working together with law enforcement and relationship building to make that happen. Is there any questions?
Question, Mary Jo and Lynn. When are you involved as probation and mental health? Are you involved only when the individual is released? Or do you have some conversations, maybe starting as early as booking or shortly thereafter? Because we know clearly from the discussions with law enforcement over the past several years, and that's the reason right now we're looking at some modifications within the jail to accommodate these things. But how early are you involved?
Well, we have intake, and then we have our PSI unit, and then, so right now, we would probably get involved right after the PSI is completed. Unless we have
Pre-sentence investigation.
Pre-sentence investigation. There are times, though, that we might have someone, on probation that ends up getting in trouble again, and then we're involved right away. So it depends on the stage of where the person is at. And I know that there are programs like in Benton County where the jail has, I believe it's Benton, that they have looked at having a mental health unit there. And so then, those things the mental health has come up before we're actually, in the pre-sentence investigation stage.
I know that MEND has mental health professionals that are, on call, and I know that Sheriff Helene has said we've certainly utilized, and I know Mr. Hartog as well. But is there or should there be more? Yes. From a state level, are we integrating and incorporating more of the best practices? Are we using more of the communication? It's prevention, all of that type of thing. So from a professional associations, are we looking at those best practices and the evidence-based outcome and positives, or are we kind of out there on our own? I'm,
Do you want to handle that?
Yes, I'll jump in on that. So first of all, we'll backtrack to your first question. And one of the things that came about is we have a transition in our office where we have a pretrial unit that takes those cases at the beginning. And so we are going to try and address any mental health concerns we have right at the time of from the release from the jail. And right now, in the state of Minnesota, with our bail studies and the different things I talked about in the last couple months and how things have changed, we're really looking at moving more people out of the jail as quickly as we can to reduce some of those negative impacts of being involved in the jail, not having access to their mental health counselors, that they may have access to the MEN program and counselors there if they don't have somebody, but one of the advantages of being out in the community is they can stay stabilized with their providers that they've had for long term. So we want to get them back out into the community as quickly as we can and provide some of that supervision. The other thing is if they're in jail, they might become homeless. That's a lot of times where we have risk of them becoming homeless because it's pretty hard to pay for your rent or keep your possessions and different things while you're sitting in jail if you don't have the support system to assist you. So we're really trying to push a lot of these individuals back into the community as soon as it's safe and provide that supervision through the pretrial unit. This caseload, our mental health unit, they really take it at the time at that sentencing level. Sometimes they may take the pre-sentence investigation, but after that they move into the sentencing. Your question, I think as a state and as agencies, we're doing an awesome job of really starting to look at how we can work together. As you can see, I mean, part of the presentation was all of the different agencies. We come together, we discuss things, particularly with law enforcement and different ideas of working on first responder issues, developing some of those crisis intervention techniques through probation and law enforcement. So we have a lot of different areas there. We're also at a state level looking at how do we provide services in the jail, but also in the prison system, because as we've talked about, 97% of our offenders that go into prison are coming back out. And so how do we address that at a state level? And we know that a lot of those offenders are not getting those services when they're in the jail, so they do, or in the prisons, so they start over. So we're making progress, but there's a lot of work to come. So.
well, I appreciate that. And it's no different than the medical units, whether it's a hospital or clinics, we have, again, those gaps in the continuity or continuum of care. We have those huge gaps, and starting over, whether it's a physical illness or a mental illness, sets us back substantially. So I'm glad to hear that at that. Mr. Burke.
Yes, I had a question, but a couple of comments. It's certainly obvious that big steps have been made in closing some of those gaps. There's always going to be gaps, but I'm so glad to hear that all this working together between the different departments and different agencies involved, especially in the mental health area. And also glad to hear you to emphasize that, I'm not sure what the percentage is, but a lot of time you talk about the correction system and the mentally ill, that the vast majority, do not end up in corrections. And it's like any other health issues. So to clarify, that was really good. My question is then, it sounds like you get involved after they have a mental health diagnosis?
That's correct. Yep.
Okay.
I unplug it.
So sometimes they come to us, though we don't know what their mental health diagnosis, so it's a lot of hand-holding to get them to the professionals.
So you are part of that then?
Yes,
too.
to get them a diagnostic so they actually have an understanding of what they need to be working with, connect them with the psychiatrist so they can get medications. A lot of it is they have so much autonomy in their mental health. They don't have to do any of these things, but by building a relationship with them and talking through these things, you can help them understand why it would be in their best interest to do those things to keep them out of the system. We don't want to criminalize people who have mental health diagnosis and who really need help. Another thing I wanted to point out is the concerns I have with so many of the mental health people that I work with are victims themselves, and they get victimized over and over in the community, be it through drugs or sexualization or just, it's hard to watch. So you have to have a lot of empathy to have this caseload, and I think that Mary Jo and I work hard to do that. Corky, yep, can I, so part of the process is that we've talked about, we start with pre-trial, and then we have pre-sentence investigation, and at that level, at the pre-sentence investigation, we're going to identify the needs of the individual as much as we can. It may not be a diagnosed
as Lynn said. It may not be a psychiatric diagnosis, but we're going to identify those needs as, oh, this is somebody who needs this extra level of care. And then they're sent to, specifically to this mental health caseload to help address some of those needs. It doesn't mean that other probation officers aren't dealing with mental health cases. It's just that the ones that we have identified to go to this unit are serious and persistent mental illness cases that for some reason has impacted their recidivism rates or their criminal offending. And for us to reduce their recidivism, we need to address these needs.
Further questions of Lynn or Mary Jo? It's rewarding, as you point out, Corky, the changes. And we didn't hear about these things 10 and 15 and 20
Or
years ago.
17, yeah.
Yeah, It was not talked about. It was there,
It was
was
there.
always
It
there.
wasn't talked about.
but we didn't identify it and we didn't verbalize it. And now we're taking action to those types of things. And it is, the changes are, to say it's paradigm is an understatement, significant. So thank you very much.
It's rewarding to have people change their lives.
Mr. Chair, I just want to talk to Mary Jo off the, on a different topic,
Oh,
away from the mic, having to do with my Washington DC trip.
We will
for
do
just
that.
a moment, so
Oh.
We will do
before you run off to your regular
oh,
job.
okay.
It doesn't appear as if
So
Dawn,
stick around.
it doesn't appear as Dawn is
Do it right now, and then you can,
So,
Okay.
any comments that you have, Tammy Jo, administrative updates?
No, the only thing I did bring a statistic, and I think next time I'll have more statistics as we're looking at it going, but I just wanted to kind of mention starting going forward. So as of July of this year, I brought up to you a couple times different numbers of cases that we've supervised in our department. And as of July 31st, we had 2,039 cases under supervision in my department. And so going forward, I'm going to try and break that down for you a little bit in terms of felonies and gross misdemeanors and gender and different things, but just wanted to kind of give you a quick update. So that's 2,039 cases, which equates to 1,594 individuals under supervision in the month of July.
So they have different offenses there.
So yeah, so when we differentiate between cases and individuals, it's because some individuals have more than one open case. So, okay,
Anything further?
no?
We're adjourned.